Oh, very good. I can see Campbell Tiley has just jumped on. Thanks for joining us, Campbell. Welcome to the GP Collab panel. Can you hear us okay?
Yeah, I can hear you. Have I got my microphone on?
Yeah, there you are.
There
Yeah.
you go. Technical genius like everyone else. Yeah.
Did you want us to go around the group or just quickly introduce ourselves? You might not know all the GPs on tonight. Does that suit you?
Yeah, sure. That'd be great. Thank you.
I'll just buzz down the list. Amita, you're first on the list.
Mic
Okay.
off. Yeah.
Microphone. Sorry. Hi, I'm GP up at the northern end of the Central Coast at Gwendolyn.
Right. No, nice to meet you.
Thanks, Amita. Con, you're next there.
Hey Campbell, I'm Con. I'm a GP down in the entrance.
Okay, great.
And Taya? He's got 3 seconds to respond.
Oh, sorry. Hi, I'm a GP at Point Clare. How you going?
Fine. Is that? Yeah. Well, I'm a hematologist, obviously, or maybe not, and based at the hospital, and am the director of cancer services there. So happy to talk about anything you want me to talk about. But I guess our cancer MDTs was the topic of the evening, I think.
Yeah, thanks, Campbell. Yeah, we do have a few more GPs, just Georgia Page and Nat Cordawina, and myself, I'm Ellie Warren, who you know we're all based at Your Family Doctors in Erina as GPs, and we've got a representative from Health Pathways here, Erica Drew from the PHN, and some other people who you know from LHD, I believe, Fiona Wilkinson and Maya Smitron. So that's everyone on tonight. Thank you so much for joining us. It should be good. We've been talking to Elizabeth Rennicke a little bit about getting GPs involved in MDTs, and we keep getting stuck with a few sort of logistical hurdles. So it'd be nice to hear from you what you think from your end, I guess, and how to progress things.
I mean, I think I would want to start by being really clear what MDTs you're talking about, so that I talk about the same type of MDT. And I mean, as I see it, within our service, there are two, completely different multidisciplinary team meetings, referred to often, with the same acronym. And I guess I'd really like to be sure which one we're talking about. I guess the sort of cancer treatment planning MDTs that we have are one of those, which are, in our context anyway, very much focused on new cancers and treatment decisions, with mainly medical/surgically focused, although many of the MDTs, depending on when they're held, will have quite a bit of nursing, and we have a pharmacist along as well, and obviously RAD-ONC and MED-ONC dominate most of them. And obviously there's the completely different type of MDT, which, are ward-based and relating to often, changes in treatment planning for patients and that sort of thing, which are often much more nursing and allied health focused. So I had the impression it was the former that we were talking about, but I guess I need to check.
It's definitely worth double checking, because I think I'm not sure that some of us as the GPs know the specific differences between both, and I think our discussions previously have centred on the ward-based MDTs. So we are super keen to get involved in your oncology MDTs, if there's at all a way to do that. But Fiona, did you have anything from your end to just expand on for Campbell, to make sure we've covered off everything we need to from things that we've already discussed on the panel with Elizabeth?
Probably not, Ellie. It was real. I think the discussion is focused around how GPs can be involved in the care of their patients, and Elizabeth put forward some options, and I know, Campbell, it's very challenging with timing and the fact that often there's discussions on multiple patients in a meeting, and so that those logistic challenges are a real complexity. So the discussion's really focused on opportunities, and is there an opportunity that it would work to actually engage with a GP?
I mean, I think it depends. Probably some background which won't surprise you, and they're issues that are going to be very common to your part of the world as well. Organisation and sort of any kind of clerical kind of support for our MDTs, administrative and clerical support, is almost non-existent. There's one part-time person supporting all of the cancer MDTs. That's not necessarily a limitation. We don't have a dedicated kind of management software package. So, and I must admit, the way I think some of the MDTs are documented and run is probably not, sort of documented and organised is probably not quite as well as I would like. But on the other hand, they're run in a way which works well for the chair and the people that attend the MDT, and the fact that those MDTs occur and discussions occur about, collegiate discussions occur about patient treatment is important, and it's more important to have the meeting perhaps conducted in a way that is less flexible from the point of view of getting the GP involved than not to have the meeting at all. So I guess, again, I'll show my inherent bias by talking about the haematology MDT, because as it happens, it probably offers more potential than any of the others at the moment. And the reason for that, I guess we use our oncology information system to sort of organise and run our MDT, which is not the most flexible of systems, but I guess it does allow us to at least generate a patient list. It doesn't necessarily have times against the patients, which is a potential problem if a GP wants to dial in for one patient, but it does know who we think the GP is. So that might be wrong. It gets pulled from the hospital PAS, and as you would know and we would know, sometimes that's accurate and sometimes it's not. But mostly those patients have been referred more recently, so it's probably a bit more likely to be correct. Unfortunately, that system's perfectly capable of sending notifications out electronically, but we're hobbled by what I think really are short-sighted policy issues, but issues outside the local health district. They're issues in health IT. So one thing we can't do is automatically send a notification to a GP when one of their patients is listed for a meeting. Although, if there's interest in going down this track, I can certainly look at, producing a bit of paper potentially that, would need to be faxed or something like that. So to me, just kind of thinking through the problem, the first thing is letting you know when your patient's going to be listed at a meeting. And we could potentially semi-automate it the way we run our meeting. I'll come back to the other meeting shortly. With various degrees of difficulty, they would find it more difficult. So if there was going to be any trial, it would probably need to be in our MDT. I guess we could possibly have to think about it. As long as we've got an email for the GP, I would have to prevail upon our part-time clerical support, who supports all of the 7 MDTs, to see whether they could, if we've got if we're discussing 8 patients or 10 patients and we've got GPs for 7 of them, I could discuss, can we add the GP? We'd have to manually add the GP's email addresses, to the notification for the meeting. And I mean, if that happens, that notification goes out with the patient list and with a, currently it's a PEXA dial-in. That's what we use because it seems to work best, but that is accessible from all over the place. We've got VMOs and radiologists dialing in from external to the health service. I mean, that's the sort of thing we would need to look at doing. If we did do that, then, you know, the GP would get an email, whatever email address we had, and I'd actually have to look at, just write a few things down while I'm talking, and I'll talk for a bit and then let you interrupt me and ask me questions. But as I'm thinking through it, I mean, whether we've got GP email addresses is another question. But if we had them and we sent that out, it would potentially be open to that GP. I mean, there's, you know, I would obviously talk to my colleagues and make sure they were happy, and I'm confident they wouldn't have any objection. It would potentially be open to that GP to dial into the meeting. Unfortunately, the GP would have to guesstimate when their patient would be up, but we really have no way around that. I mean, we finish one patient's discussion when it finishes and then move on to the next. But, you know, if the GP's there for an earlier patient, it wouldn't really matter. I think the next shortcoming is the meetings tend to be reasonably, the discussions are pretty brief. I mean, we've got a patient summary, which the haematologist puts in. We don't discuss too much about, unless it's some very unusual situation, you know, we won't go through chapter and verse about prognosis and outcome with the various protocols, because, you know, people know that by and large. Certainly we sometimes have quite long discussions about that when it's some unusual situation where the haematologist is scratching their head about what to do. And I mean, while there's stuff to discuss, we try and take as much time as we need, but there's certainly not long drawn out discussions. I mean, if we've got 12 or 14 patients, we will do our best to do them within that hour so people can get on and do whatever else they need to do. And it's mostly focused on, with some patients, obviously, particularly older patients, you know, should we treat them or should we not? You know, is it reasonable to palliate this person from day one? And, you know, obviously with younger patients, it'll be, are we aiming to transplant them or what's the plan? But it's pretty much focused on those sort of treatment decisions. So I've sort of ranted a bit about and highlighted about some of the problems we have, which can make, if we trial something, you can probably foresee how there could be some small glitches here and there. But I mean, that's probably something that if there was interest, we could trial. I don't know that, as I say, I'll have to check where I would find email addresses, because I think we have to email this thing out to you, or you haven't got the links in a convenient way that you can use them. Although, you know, it's possible to dial in on a phone. So that's how I'm thinking at the moment. I don't think it's impossible, but it's not that easy, and it wouldn't be as painless for the GP, you know, as you would potentially like, because obviously all the other folks coming to the meeting are coming for the whole meeting, so when they know when it starts, they just don't know when it finishes. So I mean, can you see any interest or value in trialing something like that?
Is it from my
the sort of
perspective?
thing
Yeah.
you could do.
I think it sounds like you've just got to jump in and give it a go, doesn't it? And just see whether there is an interest. If you do manage to get the 8 emails for those 8 GPs that own those patients, I guess, and no one turns up week to week, then it's a dud idea, I guess. But is it useful for GPs to be involved in those sorts of decisions? We, I guess, bring a different lens to those discussions, but we wouldn't want to come in expecting to talk for 15 minutes about our own patient when you've got 12 to get through in an hour. So it might be 3 minutes, and that. We don't want to make you run late.
Oh, look, you know, I mean, obviously it's it could be relevant, obviously. I mean, you know, if it's a patient well known to the GP, you'd know more about their social family situation, about their level of function. We will have, with the older patients, you know, they're things we will have tried to suss out to the level we need to, which, you know, probably isn't super fine-grained, but certainly with some of the older patients that, you know, I'm sure it would be helpful. So, and, you know, I guess we've got younger patients with who we think may have, you know, social support or psychological issues with coping with the sort of treatment we're thinking about. So, I mean, I think there are lots of aspects that a GP could contribute to. Then again, we're not talking about really detailed nitty-gritty planning. It's pretty much, you know, the go no-go decision and what we're going to do, and then, you know, there's obviously more discussion after that. But I mean, I'm sure it could be useful, and it would be useful if the GP was, you know, clear what was going on with the patient as well. That would obviously be very useful.
Yeah, that's where this stems from, isn't it? Yeah, that information coming back to us. So if that just means that it's a summary of what was decided in the meeting that is sent to us in a timely fashion, that might be all that we need, and a way for us to feed back to you.
Well, that happens I mean, from our meeting, you know, we generate a summary, which is pretty terse, but we generate a summary on every patient out of Mosaic, and that summary gets sent to the GP. So that's been happening for 2 years. So whether they ever get there or whether anyone ever sees them, we've never had any feedback on them. They're pretty brief, and that's because all the information's manually put in by us, and well, probably because I can't type well enough, I can't touch type well enough, and I've structured the system around that. You know, other younger members of the department can touch type a lot better. So maybe the summaries will get longer with time. But we do that already. And in terms of getting GPs' email addresses, we have no resource on the you know, 2 days before to say, oh, we need these GPs' email addresses. I mean, I would get lynched if I volunteered our coordinators.
Yeah.
To do that.
No, I think that's a wider hospital issue as well. Like it's a question for the wider hospital and PHN as well. Whether PHN can help with that. If the hospital doesn't have GP practice emails, how do we make that available? Because that's important to all departments, I imagine.
Yeah, exactly. And I mean,
sorry, Campbell. I was just going to say, to run a little test. Could Ellie perhaps? We just start with a small group that put their hands up that, Ellie, you go out and say, is anyone interested in this? And then we can quite easily collect that known group, and then you need to recognise the patient related to those, Campbell.
I was thinking if we were going to do this, I would have thought we would send out an expression of interest thing. And with a very brief explanation of what people could expect. And if anyone was interested, they could email back and we would put them on a list whether we can stick them in Mosaic, so that, actually we probably can't. I would be asking whether we could stick them in the PAS or somewhere if they agreed to that. If they didn't, we'd just stick them in a list on a PC somewhere, and try and find a way of, see if we could sort out a sensible way of just dealing with them. I mean, the best thing for us to do if we did get GPs' emails would be to also get permission to stick them in the PAS if we could, so that that's a source of truth, because that's where our system pulls all the GP demographics from, and patient demographics, and then our system would know if there was a GP email address, and we could print it out on something, and it would then be sort of workable for our admin support to actually do this, and it would potentially be translatable to another MDT potentially, but I mean none of the others.
Yeah, Taya's just asking if anyone has seen your MDT summaries at the other GPs in the group. She hasn't seen one, but the other GPs, have you seen an MDT summary? I think I had one come in last year, but just one.
Yeah, I don't think.
No.
I mean, heme. I suppose heme diagnoses are, well, they're not that uncommon, not super common, not that uncommon, but yeah, that was going to be one of my questions for the meeting. Has anyone seen one? And are they useful or are they not? But
they would be useful if we got them, I guess. Can we do an audit of that somehow, just to make sure people are receiving them? That would be important to know, wouldn't it?
Potentially, but it's it's auditing an indefensible 20th century system, which, you know, I've brought it up regularly for a decade or so, or more really, but certainly, you know, in recent times, it frustrates the hell out of me that our discharge summaries get emailed out. I don't know whether they arrive at you guys either, but they come out through the electronic drain pipe that goes from us out to health and then out to the world, and our documents go through that same pipe, but we're not able to route them in the same way for reasons that eHealth can't really clearly explain, except that it's not a priority for them.
So do you know how they arrive? Is it in My Health Record?
I really don't know. I'd have to ask these guys. I'm told discharge summaries go out electronically through that pipe, but I don't know how they end up at the GP practices.
They're into My Health Record, and we have lots and lots of problems. We have a lot go out, but then getting access is a bigger problem, and we all know it's a very difficult and frustrating thing to solve that we're trying to work on. But Myron might just follow up on the route of arrival for those reports. I think we might go back to Kirsty Toms while Kara's away and just see if she knows where the mosaic reports go.
Absolutely, Fiona, and I was going to propose the 21st century solution, Campbell, for you. And this is voice activated summary taking. How is that? All the slow typers.
Given that we're only talking to ourselves, apparently, it doesn't really matter. But I mean, Liverpool and Wollongong did run a project for some time doing exactly this out to GPs, and look, I gather there were some warts with it actually being able to track arrival and get a message back confirming arrival, but quite a lot of work's been done on it, and it's just interesting that it's regarded as such low priority, this sort of communication out to general practice in a way that will actually get into your systems.
Yeah, that might be. Messages are getting through to us, and we'd be happy with just that timely communication. It might avoid the need to jump into the MDT.
The messages are being sent in exactly the way as letters come from our department. You know, they're basically printed out by the same people because they've got to do that, and which is just shocking, and either faxed or mailed or whatever, you know, whatever mode of reception we've got. So anyway, that's just an admission of, you know, horror. Yeah. If there was, I'm more than happy to. What could we do? Well, look, you just have to send us some patients that we're interested in discussing, and but look, I guess we can try. We can. We'll do that. We'll at least. I'll talk to the troops about, because we've got no way of actually auditing whether these things have been printed. We can't do that. We can't do it with our letters either, which is a problem. But, you know, we just try and have systems to deal with it.
Would it be possible to pull a current list of patients and who their GP is, and then just check whether they're receiving?
Yeah, I'll talk to our long-suffering secretaries.
Oh.
And, we'll just. We had an MDT today, so I'll
just use that as a snapshot. That'd be good, yeah. And the email.
We'll just see if they arrived.
The email issue is a larger issue. We should follow up as well, Fiona. Can we add that to our list to action as a group, just to make sure that's happening somehow?
Can do. I'm just emailing ICT and health records as we speak. Campbell, what's the name of that report? Mosaic. The Mosaic report.
It's it's an MDT summary, but okay. I mean, it doesn't get sent it gets sent to PowerChart, so it gets sent to the EMR. Okay. So it traverses the pipe, and those electronic routing machines that it goes through can potentially, the LHD could send it out, but there's nowhere to send it to that will get to where it needs to go. That's the problem. So I don't think there's any difficulty the LHD sending it out into the ether. It just can't actually be addressed in a useful way so that it gets out to one of the one of the mobs outside that can actually then route it on to the GPs.
Yeah, I really wonder if this gets kind of sent to the My Health record. It would be really interesting to see. I'll speak to Kirsty, Fiona. What do you think? I think that's a good start. It doesn't, Campbell?
Well, you're welcome to tell me that it does when you have a look, but I put a fair bit of money on the fact that it doesn't.
It doesn't, okay.
It stays internal to the LHD apart from the ones we print out and try and, poke out the door.
And then my question, should it be actually sent to My Health record? Is this the best place to actually send those?
If we were going to send it there, I would check. I don't want to offend my colleagues, but again, I'm sure they'd have no problem with that. I think, or the only problem with sending something like this there is, if all the subsequent correspondence relevant stuff doesn't go there, I mean, plans change and they can change within a week or two. I mean, it really has relevance. It's a document that really has relevance at the time, and, the GP or, the emergency department or someone, if the patient comes into ED, are really the people who are worth informing. And once it's 2 months down the track, it's not the right document. There should be other correspondence, which is more informative about what's happened and, where the patient's at. So if stuff was going to My Health record, it'd be a good discussion to have. But in actual fact, I'm not sure this would really be the right thing to go there, unless that was actually an effective way of. Well, I mean, if the GP doesn't know it's there, they can't look at it. So.
I think it would be better to go through secure messaging to the GP, because then don't you as GPs get a notification that you've got a new piece of mail, a secure messaging new mail?
Yeah.
So that would be better.
From our side of the fence, exactly that has been discussed ad nauseum, really, and it's something that. Well, from my perspective, it'd be, I mean, general practice, you guys may have been discussing it ad nauseum as well, but I mean, the more it gets raised with health services as a really important, patient safety, patient care initiative, and probably be raising it from outside is more likely to get attention than raising it from inside.
Yeah, thank you, Campbell. Just in the interest of time, I guess we just better make sure that other GPs are happy. Did you guys want to ask any questions or comment while Campbell is here, just on either the idea of GPs being involved in heme oncology, MDTs, or what we've been talking about with secure messaging as the summary? Amita?
Look, I can assure you that I think we do get discharge summaries. I don't know about your notes from the MDTs. I would have to look at a couple of patients, but we certainly get discharge summaries. They appear to, they seem to come from the hospitals far better than they used to in the days of paper envelopes coming with the patient. So that's something that's reassuring. I frankly have my doubts from what you're describing that a GP is going to, in the middle of their busy day, be able to find that time for a 3-minute consult, like contribution in the MDT meeting, to be able to say, yeah, you know, I've got something of value to contribute, that I'm going to be on hold or whatever for all that time. So I'm not sure that there's a lot of value in that, frankly.
Yeah, I'm not suggesting it because I think it's useful. I'm just trying to paint how the meetings run.
It could be useful, but practically, the practicality of when you're consulting and how the meeting is run, it sounds like it might be really difficult.
Yeah, I mean, it's that's been our view really as well.
Yeah, and something as simple as a phone call from one of the RMOs after the MDT might be all we need as well. Just a quick chat or a question, if you know, and that's a schmozzle at the moment for you guys as well, isn't it?
Well, they're not always at the MDTs. You know, they're usually pretty busy on the ward. They don't have time to attend at that time. Usually, some of the MDTs happen after hours. I really don't. I don't think that's going to happen. I mean, if we could put in a system, then that would work. I think that can happen. I think making sure these notifications get to you would be a plus. I guess the next thing I would raise about that is that most of the MDTs really don't have a system that can notify you after the MDT. So if our system's not working, well, we obviously need to fix it so that it is working the way we expect. It would be great to get some feedback as to how useful that is one way or another. If it was regarded as useful, then that gives me something to take back to the other MDTs and apply some pressure as to all the reasons why they need to lift their game. And they could, it's probably more difficult for some of them. We're familiar with using Mosaic, so we can use it, but it is built so the other MDTs could use the same functionality. One of the MDTs, probably the next, well, really one of our very functional MDTs, a number of the members were interested in using this system because it can produce immediate documentation of the decision at the meeting. And interestingly, one of their members was very unhappy about having the opinion of the meeting actually recorded and put into the EMR and sent out to the GP, and he felt this was a big problem. So, you know, there are challenges, but and a couple of the surgical MDTs are really, you know, they document things, you know, on, I think they do actually document the outcomes, but they're documented in a way that is not visible to anybody except them. And that's more of a challenge. But, you know, I think if we know that, you know, if we know that there's significant value seen in something happening, some change, it does make it a little bit easier to push the issue a bit.
Agreed. Con, did you have any other thoughts before Campbell goes?
No, that's all understood. Yeah, probably may just try this, you know, sending of the summary of the MDT, see how that goes. Of course, we haven't received them so far, so if we can send them out, we can, you know, feedback on that.
Well, anyway, as I say, I'll do the 1 week audit. Yeah. And yeah, I might find something out that surprises me. And look, I'll send some de-identified summaries to Ellie, and she can you can give us some feedback. As I say, they're very brief, but
yeah, that would be really good actually, Campbell. That'd be great. Yeah. Thank you so much. Was there anything else? I think we can call it a night. Thanks for joining us. If everyone else is happy.
Thank you.
Yeah. Thanks everyone.
Well, thank you.
Thanks so much, Campbell.
See ya.
Yeah, lots of challenges.
I think,
not easy.
Yeah, just in the...
Okay, thank you.
Looks good.
So really, as I said before, I wanted to just mention and talk about sort of the changes to palliative care over the last few years. I think it started in 2015, the area did a palliative care